Excellent. Great to see so many of you here. Good evening, everyone. I'm Joan Costafon, and I'm a professor of health economics here at the school. And this is an event hosted by LSE Health that celebrates its 30 years of existence as a research center at LSE. And as you all know, LSE Health is a major research center that has helped bridging health research and policy making across the world. It has had a huge impact on health decision making, and this impact has been recognized with a number of awards, like the Queen's Anniversary Award back in time, and more recently as well, the Further Education Award. Just let me, before proceeding, give you some practical announcements. Apparently, we have LSEs asking us to tell everyone that in the event of fire, we need to reconvene around the corner in front of Pankhurst House, right? So remember that. And then, ideally, if you could turn your mobile phones on a silent mode, would be great, so that they don't and I probably should do that myself, so that they don't interfere with the speaker's speech. This event is actually being recorded, so behave. And the event will last about 50 minutes, and then we'll get like 30 minutes for questions. So you'll have an opportunity to ask questions later. Now, as I was saying, this is an event which is part of LSE Health 30th anniversary, and we are absolutely delighted to welcome Janet Currie to examine a really important topic, the issue and the realities of child mental health, and particularly child mental health crisis, which is a very serious crisis going on in many Western countries, and it's actually a major concern, both by policymakers, expressed by policymakers and health professionals, as well as by families. And she will be touching upon really important points related to the misconceptions of what's going on and what explains this crisis, about the nature, the origins, and the solutions to this crisis. And particularly, there's three main misconceptions that will be discussed, which I think are really important. The first one is that this is not a recent crisis, but a crisis that has actually historical roots. The second one is that suicides, the rise in suicides amongst younger populations is actually not necessarily a very good proxy for for youth mental health or mental health among children. And finally, another important message that this talk will reflect, and you get to hear it yourself, is the point that policy interventions have something to do, have something to change, so we can actually change this kind of gloomy sort of forecast with policy interventions. Let me introduce a little bit, I know that most of you would know Janet by now, but let me introduce Professor Janet Currie, which we are very honored to have here today. It's such a delight and a pleasure to have her. I was a bit nervous today because she was literally on the list of potential Nobel laureates. And I thought, I don't want to see the lots of journalists here taking pics and disrupting the event. No? So I'm actually delighted that at least this year she hasn't been awarded a Nobel Prize. But I would just, I think it would be fair to say that Janet is one of the pioneers in health economics research these days, and her area has been very much touching upon inequality, child health. In fact, she directs the Children and Families Program of the National Bureau of Economic Research, and some of the research touches upon a number of really important questions, mostly using methods of the credibility revolution, like the causal methods that are so common in economics. As a trained labor economist, she's using them very well. And some of her research actually touches upon really important questions on climate change and youth mental health. So really important work. So Janet Currie is a professor of economics at Yale University, and until very recently she was a professor of economics and public affairs at Princeton University, where she was the director of the Center for Health and Well-being. As I said, she directs this program on children and families in the National Bureau of Economic Research, and she's a member of the US National Academy of Science, the National Academy of Medicine, the American Academy of Arts and Sciences, the British Academy, and until very recently, until 2024, she was the president of the American Economic Association. She has received a number of awards, including being the top 10 women in economics by the World Economic Forum, the Klaus Jacobs Prize, Research Prize in 2023, and the Clarivate Citation Laureate Prize or Award in 2024. She holds a number of honorary degrees from the University of Lyon, Zurich, Università della Sibera Italiana, and she's been actually very active in policy, including advising the White House or speaking in the White House and the European Investment Bank. So I could go on and on like this, and we would not have the event, and I'll just keep on it. I would be introducing Janet. So without further ado, please welcome Janet Currie.
So thank you very much. I must say that's a unique introduction to be introduced as the person who didn't win, didn't win the Nobel Prize today, but that's kind of fun. So as Juan said, I'm going to be talking about investing in children to address the youth mental health crisis. And we all know that this is a very important problem. It's been described by the former Surgeon General of the United States, Vivek Murthy, as the public health crisis of our time, which I think is really remarkable if you consider that we just came out of this worldwide pandemic. The American Academy of Pediatrics has also declared a state of national emergency with respect to children's mental health. So, as Juan foreshadowed very well, I'm going to talk about three things. First, I'm just going to give a little bit of background about the economic cost of the mental health crisis. Then I'm going to focus on two myths that I think direct attention away from things that might be useful to do. One of them is that this is a new crisis, which I think is just false. And the second is that basically mental health measures and suicides track each other. And I'm going to show you evidence that they don't really track each other all that well. And then third, I'm going to talk about investments to improve youth mental health and hopefully to prevent suicides. So thinking about the costs, the main element of the cost is just the sheer number of people that have mental health problems. So about 13% of US children are estimated to have a current diagnosed mental health condition. And these child mental health services cost about $31 billion in 2021, which is almost half of all child medical spending. Why is it so big? Well, because there's so many people, right? If you think about anything else like childhood cancer, which might generate high costs, it's affecting a very small number of people compared to this. So that's why it's so big. There's the direct costs to children themselves, costs of medical care. There's also a lot of costs on parents and families, just indicated by things like lost parental work time. So I also looked up some numbers to see what the size of the crisis was here in the UK. And according to the Mental Health of Children and Young People in England 2023 report, there's something like a fifth that have a probable mental health disorder. So that's not exactly the same as what I was showing you for the US in terms of a diagnosed mental health disorder, but it's still showing kind of similar order of magnitude in terms of the size of the problem. And this matches up quite well with what UNICEF says the scale of the problem is worldwide. So I think we could take it as a good number that there's somewhere between 10 and 20% of youth that have some sort of mental health problem, which is impairing their daily life and imposing costs on themselves and others. Now, the most tragic manifestation of this is in terms of suicide rates. So what I'm showing you here is data from the World Health Organization's mortality database for the US on the top and the UK on the bottom. You can see a number of things from here. First of all, the suicide rate is kind of almost always and everywhere much higher for males than it is for females, which is an important thing to keep in mind when we're thinking about the relationship between mental health and suicide, because mental health problems measured anyway are usually greater for girls than for boys. You can also see here a kind of U-shaped pattern in the US, where rates were pretty high at the beginning of the 90s and then fell until about 2008 and then have been going up. Similarly, in the UK, you see that rates were falling. They actually fell pretty sharply between 2000 and 2005 and then started to go up again. Now, one of the things I want to highlight is that these rates are actually quite different in the EU. They're lower in the EU and the trend is different. Okay? So I want you to keep that in mind when we're thinking about possible causes, because it would have to be something that's sort of different in the US and the UK and not so much in European countries. Okay? Focusing in those two pictures, you couldn't really see what the difference in the levels was, so I've plotted them here on the same plot. The suicide rates for 15 to 19-year-olds in US versus England and Wales. So you can see this U-shaped pattern, but you can also see that the rate is much higher in the US than it is in the UK. So, as I said, that's one of the more extreme manifestations of the youth mental health crisis, but there are also costs on survivors. It's estimated that about 50% of adult mental health conditions start in childhood, and child mental health is actually more predictive of negative adult outcomes like lower employment probabilities, lower wages, higher rates of disability than common physical health problems. So this figure is showing how within a sibling pair, the child who has worse mental health, which is indicated on the x-axis, so as you get a bigger number, that's a worse index of mental health, is less likely to still be in school than their own sibling at age 16 to 19. Okay, so that's one way that it has negative effects on people, by reducing the probability that they stay in school. And then this figure is showing, I should say these are for Canadian children using administrative data. This figure is showing the probability of being on social assistance after age 18 with a diagnosed mental health condition compared to two common physical health conditions. So in this sample, the most common physical health conditions are asthma and major injuries. And you can see those have much less predictive power for being on social assistance than having ADHD or conduct disorders in childhood. Once you get to adulthood, you can also see the high cost of mental health disorders, looking at data on working days lost, for example. So these are people who are actually employed, but losing some employment because of a health problem. And their mental health is the leading cause of lost working days in the UK, followed by musculoskeletal conditions like lower back pain, and then everything else being a distant third. So these are kind of the two big reasons why people lose work. Okay, so that hopefully convinces you that this is an important problem. The next thing I want to talk about is how new is this problem? And we hear a lot about this explosion of youth mental health problems, particularly since the pandemic. And I think there's an impression in people's minds that this is new. And this is feeding into the idea that it must be caused by something new. And everybody, the new thing on the block is social media, right? So it must be caused by social media because it's only happening after social media really took off. Okay? So that's why it's interesting to find things like this. This is a report to Congress from 1970, which is using exactly the same language, crisis in child mental health, this time challenge for the 1970s. I guess the 1970s didn't rise to the challenge. But the number here is the same as the HRSA's 13% number. So even though the system of diagnosing people and so on was completely different, there was still an estimate that approximately the same number of children had a mental health condition. Okay. You see the same thing in 2000. Then Surgeon General David Satcher called for national action to address the children's mental health crisis and estimated that about 11% of children were suffering from a significant impairment. So you see this remarkable stability in the estimates of the number of children who are being affected by mental health crisis over decades. And I think this high rate should not be very surprising given what we're learning about the causes of mental illness. So we now know, for example, that severe maternal stress in utero is associated with mental health problems in offspring. We know that stressful events in early childhood, including poverty and other types of stressors, are associated with later mental health issues. And we had a lot of problems like those in the past as well, right? So they were there and they were leading to mental health problems as well. Oops, sorry. So given that we have this sort of high rate over a long period of time, what accounts for the rapid increases in measured rates of mental health? And I think some of it, I'm not going to say there's no increase in true prevalence, because there might be, but there's a lot of changes in measurement, as well as looking at this from an economics lens, changes in the incentives that both patients and providers are facing to either get a mental health diagnosis or provide a mental health diagnosis. So this figure is showing changes in either screening, coding, diagnosis, or insurance coverage over the period 2007 to 2016 in the US. And so the point of this figure is that there was something happening almost every year that would have changed the way that mental health diagnoses were measured. And I'm going to talk about some of these things that I think might be particularly important. One of them is the change in the Diagnostic and Statistical Manual of Mental Disorders, which is used to diagnose mental health disorders. This changed in 2013 in some very radical ways in terms of the definition of various child mental health problems. So just to give some examples, the definition of anxiety changed. Post-traumatic stress disorder used to be its own thing, and now it's been folded into anxiety. So that mechanically increases the number of people who have an anxiety disorder. Similarly, there were several disorders that were added to depression. Maybe most famously, there was the kind of new category of autism spectrum disorder, which combined 4 existing categories. So before you had autism, you had Asperger's, you had pervasive developmental disorder, and there was one other more minor one, and those were just joined together in this new category of autism spectrum disorder. So again, mechanically, overnight, you had a huge increase in the number of people colloquially labeled with autism because you're combining all these different diagnoses. There's a similar thing with ADHD, where prior to the DSM-5, you had to have symptoms before age 7 to qualify for a diagnosis, and they changed the age limit to age 12. So what that means is that there's a whole bunch of people who first started to have symptoms between age 7 and age 12 who are now eligible to get a diagnosis where they weren't eligible for a diagnosis before. Okay, so you can see that these things would tend to change the number of people who are diagnosed with different things. Thinking about the incentive side of this, you think from the point of view of a patient, what is the benefit and what is the cost of having a mental health diagnosis? Okay, well, the benefits include access to medical care. And if I have a diagnosis, maybe I can get some treatment that will help me. Maybe I can get an individualized education plan in school. Maybe I can qualify for disability payments. So those are on the plus side. On the minus side, there's a lot of stigma associated with mental health, and there still is. But the evidence is that the stigma associated with mental health has been falling over time. So the cost of sort of coming out and saying that you have a mental health problem is probably diminished over time. One study in the UK that looked into this found that there were significant increases in knowledge about mental health, so the idea that it could be biologically determined, that there were improvements in attitudes towards people with mental health, and fewer responses that indicated that somebody would want to keep a social distance from somebody with mental health. Okay, so I'm going to look at, on the provider side, the incentives facing providers to diagnose people with mental health conditions using data from the US nationwide emergency department sample. So the reason why it's useful to look at emergency departments is that people who are having a mental health crisis are usually advised to go to the nearest emergency department where somebody will look after them and decide what further treatment that they need. So this is a very common thing in the US. This data that I'm using is a 20% sample of all hospital ED claims, so it represents about 30 million ED visits per year. And if I just plot out the number of ED visits with mental health disorder, what I'm showing in this graph is I've normalized everything so that starting in 2006 is 1, and then you can see the increase over time. So I want you to first look at the middle dashed line, which is the number of ED visits for any mental health disorder at all. And you can see that goes up to 1.37. So over the whole period, it goes up by 37%. Okay? Now, what are the other two lines here? What I've done is I've divided all mental health visits into those for depression, or like mood and anxiety disorders, and those for any other type of mental health disorder. Okay, so the one on the top is mood and anxiety disorders, and you can see that doubled. But the one on the bottom for other mental health disorders first went up and then started to go down. And that reflects, to some extent, a relabeling away from diagnoses like bipolar 2 to diagnoses like mood disorders. Okay, so this is an imprecise science labeling different types of mental illnesses, and if you focus on just one, it may be misleading because there are changes in how things get labeled. The other thing you can see from this figure is that all of these lines track until 2011, and then they start to diverge. So the mood and anxiety disorders really start taking off after about 2012. So what happened in 2012? Well, in the US, the US Preventive Services Task Force recommended screening women and girls for depression. And at the same time, the Affordable Care Act said that insurers had to pay for that. Okay, so now you had a directive that says you have to do the screening, and we'll pay you for doing that. Okay, and so you can see that you get this split by gender. Here I'm plotting ED visits where they've coded suicidal ideation. And the reason for that is because depression screeners ask about suicidal ideation. So if you're doing depression screening, you may detect more suicidal ideation. And you can see the split for girls versus boys after they start doing the screening in 2012. Okay, there's a second line here, which I'll talk about in a minute. In 2016, you also see an increase for both boys and girls. And I will argue that's due to another change, which is that in 2015, when the US finally adopted the ICD-10, which had been adopted in other countries much earlier, the coding, the ICD-10 encourages people to code suicidal ideation as a secondary diagnosis. This sounds very arcane, but before that, you couldn't actually code suicidal ideation as a secondary diagnosis if the primary diagnosis was some other mental health condition. Okay, so they're really changing the way that they're thinking about suicidal ideation here from saying like, oh, if you have a mental health condition and you also have suicidal ideation, that's just part of the same mental health condition. And now they're saying, no, no, it's really different and it merits being coded as a separate thing. Okay. You also see, and so this is just showing that you see this pulling away of suicidal ideation from other forms of suicidal behaviors. The middle line here is self-harm visits, and the bottom line is the suicide visits. When you look at the rates, because these things have very different levels, if you look at the rates on the bottom, you can see that the increase in self-harming behaviors and the increase in suicides are similar, but the increase in suicidal ideation is almost 5.5 times greater. Okay? So that as an indicator of suicidal behaviors, arguably that's become kind of less useful for looking at trends, right? Because it's really behaving very differently. So having done a lot of work getting really into the weeds looking at this in the US, I was asking myself, are there UK changes that might have changed reporting? And so I can't tell you that these did change reporting, but just looking around, it seems like there are some things which might have been important. The change in the DSM-5 is probably important. And then the whole change since 2011 in the government's approach to mental health services. So there was a plan introduced in 2011. In 2015, there was the introduction of access and waiting time standards, which apparently had some impact. And then over the period 2016 up to 2022, there was a very large increase in NHS mental health workforce, including a 41% increase in therapists. So you might think that that would be associated with more people getting care and more people getting diagnoses. Another important change was in 2018, a lowering of the legal standard for coroners to conclude that a death was a suicide. And this goes along with the decriminalization of suicide, saying that before you had to have a really high standard if it's a crime, right? But if it's not a crime, then you can use a lower standard appropriately, right? So that has probably had some impact on the statistics, even for suicides. Okay. So continuing talking about suicides here, I want to show you some data just thinking about how well suicide rates track other underlying measures of mental health. And I think the importance of doing this is that if there's a wedge, if suicide moves differently than the mental health measures, maybe that shows you that there's other factors that might be important and that could be addressed in addition to looking at mental health. Okay, so thinking again about the suicide rates for the US, I just want you to look at the time series trend here, where we have a big increase from 2008 up to 2017. It peaks for some reason in 2017, and then it goes down aside from a blip in 2021, which is kind of the COVID blip. Okay. So thinking about how that tracks with mental health, you need a measure that's being measured in the same way over time. And I just showed you that things like ED visits are not measured in the same way over time. So I'm going to use a measure that's from the Youth Risk Behavioral Surveillance Survey, which is a large survey of high schoolers that's been done every year since 1991. It's done anonymously in schools, and they have asked the same questions about mental health over time. So the questions I'm going to focus on are these. First, they ask, during the past 12 months, did you ever feel so sad or hopeless almost every day for 2 weeks or more in a row that you stopped doing some of your usual activities? So this is kind of similar to a definition of depression. Then, during the past 12 months, did you ever seriously consider attempting suicide? They also ask whether you made a plan. And then the last question is, during the past 12 months, how many times did you actually attempt suicide? Okay, so this is plotting out those 4 questions, where on the top is sad and hopeless, and on the bottom is whether somebody says that they attempted suicide. And what you can see is that, first of all, the rates are pretty shockingly high. And so when you hear people talking about hopelessness in the United States, this is the survey that they're talking about, and this is the question that they're talking about. And you can see that almost over the whole period that that question has been asked, the rate was at least 30%, going up to 40% during COVID. Okay. Similarly, the rate for attempted suicide is very high, almost 10% over almost the whole period. Okay. But thinking about the time series trend here, what did we see before? We saw a big run-up from 2008 up to 2017, and then a decline. And here we're seeing something that's kind of flat in terms of hopelessness, and then a big increase after 2017. So it's going kind of exactly the wrong way. Okay. Thinking about the same kind of thing for England and Wales, this is for the same age group, 15 to 19, you see a run-up between 2011 and 2015 especially, and then it sort of bounces up and down. Okay, and so trying to find an equivalent to the Youth Risk Behavioral Surveillance Study, I looked at the UK Household Longitudinal Study for 16 to 19-year-olds, where they ask about any severe mental health problem. It's a little bit difficult to match dates here because each wave of this survey lasts for about 3 years. But I put the oval to indicate the area or the time period between 2012 and 2015 when we saw the big increase in suicide rates in the UK. Then that was a period where the reported mental health was pretty flat. And then we get this big increase between wave 8 and wave 9, which is 2017, 2019, which seems like that big spike in the US around 2017. So I can't explain to you why there was that big spike in 2017, but I can show you that this is not tracking, the suicide rate and the measured mental health rates here are not tracking very well over time. This is the full GHQ-12 score from the UK Household Longitudinal Study, which shows a little bit more continuous increase over time, at least for females. Okay. So in terms of the time series, they're not matching that well. What about in terms of space? Okay. Well, if you look at suicides in the US, it's very striking what a big difference there is between different areas. So if you look in the Northeast, the rates are low, similar to rates in continental Europe. But if you look in the Mountain West and places like Alaska, you have rates that are almost 6 times higher. You might ask, well, is that because those places are more rural, and maybe it's an urban-rural thing, but looking at ED visits, you don't see very much difference between urban and rural areas in ED visits for mental health. And in fact, the ED visits and the suicide rates sort of go the wrong way regionally. So these lines are for 4 different regions. The black line is for the Northeast, which had the lowest suicide rate. And you can see it actually has the highest rate for ED mental health visits. Now, I think if you look at causes, you can get a little bit more sense about what's going on here. So what this figure is showing is for 4 US regions. The top line is the overall suicide rate, and then the other lines below it are lines for each cause. So here the green dashes are deaths by suffocation, and the dark blue dot dash are deaths by firearms. Okay? Then the 2 bottom lines that don't seem to count for much are poisonings, so that's drug overdoses, and people are often surprised that that isn't a bigger deal. And then everything else, which is the turquoise line. Okay, so you can see that suffocations and firearms deaths account for the vast majority of youth suicides in the US. And you can also see that the big difference between the Northeast and other places is it has way fewer firearms deaths, which is suggestive that that might have something to do with firearms legislation in the United States. Oh, I'm sorry, my figure has, or my equation is looking a bit odd, but those should just be betas or something like that there in those squares. So you can look at the relationship between suicide deaths, firearm laws, and hopelessness using the data from the Youth Risk Behavioral Survey to measure hopelessness. And grouping the laws according to a lobby group called the Every Town for Gun Safety, which is Michael Bloomberg's lobby group, that classifies laws into broad categories. So when I do that, what you see, looking at the first column, is that if I have another gun safety law that reduces the suicide rate by about 6%, okay, and that's conditional on the fraction of youth who say that they felt hopeless. Okay, so hopelessness is associated with higher suicide rates, but it's not the only thing that's important. So this is an example showing that actual gun laws matter. Okay? Now, another thing you hear people say sometimes is like, well, if you prevent people from killing themselves one way, they might just use some other method. And so that's why in column 2, I separate out the firearm rate, and then in column 3, I separate out the rate of deaths by suffocation, which was the other leading method, right? So if there was a lot of substitution going on, you might expect that, okay, firearms would go down, but suffocation would go up. But you don't see that at all. There is no substitution. So you prevent a death from firearms, and it seems to stay prevented. Okay. We also looked at some of the more recent changes in the US, which are not gun safety laws. You might characterize them as gun freedom laws. Everybody should have their own gun and be able to do whatever they like with it. So 2 laws in this category are so-called shoot first laws or stand your ground laws, which change the circumstances under which you could shoot somebody in self-defense, and the repeal of concealed carry permit laws. And when we look at those in an event study framework, what we see again is that passing one of those laws is associated with an increase in firearms death and no change in deaths by suffocation. Okay. I also looked into differences in suicide rates across English regions. So this is using the English NHS regions. And you can see the differences are there. They're not nearly as dramatic as in the US, but you're still having much higher rates in the worst affected places than in London, which is the best. Okay. Now, of course, I mentioned social media a little bit. Everybody wants to know, do trends in the use of social media explain these geographic differences? I think it unlikely. It's not the case that people in Montana are using social media a lot more than people in New York or California. But we do know from careful research studies that phone use and social media use does seem to have some effect on mental health. There's studies that do things like pay college students not to use their cell phone for some period of time and then measure their mental health and find some improvements. But it's very difficult to look at time series analysis because the questions about social media have not been asked very consistently over time. And you can understand, when you think about it, why that might be. Social media has changed so much over time. How would you even have asked the same questions in 2005 that you would ask in 2015 or in 2025? So I'm going to show you some cross-sectional relationships between very crude measures of social media use. So this is data from the Youth Risk Behavioral Surveillance Study, again, looking at the relationship between the suicide rate for 15 to 19-year-olds and the fraction who report that they have more than 3 hours of screen time per day. Okay? And you can see there's actually a negative relationship, and those big outliers are those states that I was showing you that have the very high suicide rate. So it's actually the opposite. They're the people that are not using social media and having the high rates. Again, trying to find some comparable data for the UK, I came across the Oxford data portal that collects information about internet use and suicide rates. And if you plot those for the UK, you see this big increase in internet use earlier in the period, and then the increase in suicide rates being later in the period. Okay, so I can't speak anything to the content of the social media, which of course may have changed and may possibly be driving some of this, but I can say that there is not much evidence that the internet use is actually causing the trends in suicide that we see. Okay, so to turn to something a little less gloomy, I want to talk now about investments to improve child mental health and hopefully to reduce suicide. And I think it's really important to talk about success stories as well as all the doom and gloom, because if people don't know about the success stories, then that really erodes public support for paying for programs which may be effective. So starting in the prenatal period, I was mentioning earlier that there was evidence that maternal stress during the prenatal period was linked to mental health in the offspring. Similarly, if you provide supports during the prenatal period, that can improve child mental health. So just as an example, I have a study that links participation in a large US program called the Supplemental Nutrition Program for Women, Infants, and Children, which provides supplemental nutrition, but also access to medical care and counseling and so on for pregnant women. And we look at children who were born in South Carolina. These are all the children who were on the Medicaid program, so it's a large sample. They're born between 2004 and 2009 and followed up to age 6 to 11. And we're just following them in the public health insurance records, comparing children who had access or whose mothers had access to this program during their pregnancies to their own siblings when the mother didn't have access to the program. And what we see is a lower incidence of ADHD for siblings who were covered by WIC prenatally, and also a decrease in other mental health conditions, which we just lumped together because there were many fewer of them, that are commonly diagnosed in early childhood. There's also evidence that early childhood programs can improve child mental health. So for example, Jim Heckman has research using data from the Perry preschool experiment, which was a randomized experiment with enriched preschool compared to a control that didn't get that. And he shows that participation in this program reduced children's externalizing behaviors at ages 7 to 9. And then the data that I was showing you earlier from Canada was showing that externalizing behaviors predict negative adult outcomes. The one that I showed you was participation in social assistance, but you can also see a relationship with educational attainment. I think there's a lot of evidence that intervention in schools may be particularly important. What I'm showing you here are suicide rates for 15 to 19-year-olds compared to 20 to 24-year-olds, and looking at the seasonal pattern. Each figure has two lines. One is for 1999 to 2004, and the other one is 2014 to 2019. So I guess what I want you to take away from this are these big spikes in the 15 to 19-year-old line in sort of March, April, and October. Right? What is that? That's midterms. Right? And you see a dip during the summer holidays and also at the Christmas holidays. Okay? So that is suggestive that there's something about being in school for the 15 to 19-year-olds, which is conducive to suicides. Okay? Other evidence about that is looking at the pandemic. So we know the world shut down in March 2020, schools shut down in March 2020, but in the US, schools are administered at a very local level, so there was a very staggered reopening. Some places reopened much faster than others, and the suicide rate fell initially in March 2020 and then went back up again with school reopenings. One reason for that seems to be that in-person bullying and cyberbullying are not complements, but are not substitutes, but complements. That is, when you have more in-person schooling, you get more in-person bullying and also more cyberbullying. And so, again, during the pandemic, Google searches for both types of bullying fell when there were school closures. Okay. So in addition to things like bullying, there could just be pressure from being in school, pressure to perform. This figure is from some research that I've been doing, looking at how school entry and exit correlates with use of mental health services in Taiwan. The reason why we're looking at Taiwan is they have very strict school entry dates. And so we can look at kids who are born in August and kids who are born in September. The ones who are born in September go to school when they're 6. The other ones have to wait for a year. So we compare the ones born in September to the ones born in August and see what is the effect of going to school. So you can see when they enter primary school, they're more likely to start taking antidepressants. That possibly could be because they're more observed by different people. But when we look at middle school, we see an even bigger jump. Those kids are all in school already, but when they move to middle school, the pressure goes up, and so does the antidepressant use. And then when they finish writing high-stakes exams for going to high school, and when they finish writing high-stakes exams for going to college, you see the fall-off in use of antidepressant use. We also have some nice studies looking at school-based services. For example, Ezra Goldberstein has a study looking at the rollout of licensed clinical mental health workers in schools in Minneapolis. He has 19 years of administrative data plus student surveys, and he's able to show that having the services in school increases mental health care utilization, improves discipline, and reduces self-reported suicide attempts without actually having any effect on academic outcomes. Other promising interventions that I just want to mention, although I don't have time to go through them, are stricter anti-bullying laws, providing health insurance, which is always an issue in the United States, providing cognitive behavioral therapy in schools along with tutoring. I talked about firearm safety laws. I put question marks on social media controls or maybe education about how to use social media in a healthier way, because I think we don't have great studies of that, but maybe it would be a good thing to look into. And also suicide contagion is very hard to study given small numbers, but I think that's a potentially important thing to look at. And I just want to highlight, to conclude, the importance of not only getting treatment, but getting good treatment. There's a lot of bad treatment out there. So this is a map at the county level for the US, where darker shades indicate more antidepressant prescriptions per capita for youth 10 to 19. And so the point of this figure is just to show huge variation, which doesn't really follow any particular geographic pattern. In some places, doctors are prescribing hardly any, and in other places, it's just like 1 per person per year. Now, not only are children getting a lot of prescriptions, but they're getting a lot of prescriptions which should raise a red flag. So what do I mean by that? This figure is for privately insured children in the US who are being treated for the first time for a mental health problem. And looking at what they got prescribed, you can see that almost 15% of them get benzodiazepines, which is a strange thing to prescribe. 13% of them get a drug which is not FDA approved for any use at all in children. 4% get an older tricyclic antidepressant. And then 13% actually get more than 1 prescription at their first incident of getting prescribed. So only about 55% seem like they're getting the thing which NHS would advise, which is, you know, if a drug is necessary, give a SSRI to start off with. Okay. Now, this problem, I think may be more severe in the United States, but also seems to be an issue in the UK. This study is talking about the rising rate of prescribing of antipsychotics for children, which has gone up 3% per year between 2000 and 2019. The rate of prescribing of antidepressants has more than doubled over a fairly short period of time. This is the author's note, is that these medications should be discontinued at the earliest opportunity, but it's actually quite difficult to taper them. A lot of primary care physicians don't feel competent to do that. And most inpatient stays, if somebody has an inpatient stay, is not long enough to do any tapering. So people end up being put on these drugs and then stay on them for a long time. Okay. Reflecting this, NHS England actually has a couple of programs that are supposed to be trying to curb the inappropriate prescribing. One of them is particularly for people with learning disabilities and who are on the autism spectrum, who have very high rates of inappropriate prescribing. And then the other one is more generally trying to encourage pediatricians to use less of these medications or use them for the right reason and the right dose for as short a time as possible. And now, this red flag prescribing, I have some forthcoming work showing that it's harmful, basically. So this is the same idea, using privately insured US children, finding children who are being treated for the first time, and looking at what they got if they were prescribed medication. Then we use the variation across local areas, which I showed you in the map, to predict who is going to be treated with what, right? So if I'm in an area where lots of prescribers are giving kids antipsychotics, the probability that the child gets antipsychotics is higher. And then we look at the outcomes up to 2 years afterwards. And this figure is sort of illustrating what we find. First of all, maybe surprisingly, we actually found that the kids who were treated with drugs had lower probabilities of self-harm after 24 months, but that it varied according to what kind of drug that they got. So the people who were getting these drugs, which I argue should raise a red flag, had higher rates of self-harm after 2 years, and the people who got drugs which were FDA approved had lower rates. Okay. So just then to conclude, I tried to make a few points here. First, that the youth mental health crisis is very costly and merits our attention, so I certainly don't want anything I say to be interpreted as idea that this isn't a crisis. I think it is. But It's a crisis that's very long running. It has existed for decades. It's not a recent thing at all. It's not a post-COVID thing. I also have showed you some data that suicide rates vary, even conditional, on mental health measures. And so I think that there are factors that are important for explaining suicides. In the US, it's definitely gun laws. Probably in the UK, there are other factors. So there are things which potentially could be addressed to try specifically to reduce suicides. And then fourth, investments in children have the potential to improve their mental health, to reduce suicides, and to reduce the overall toll of the mental health crisis.
Thank you so much. Right, so now we have time for some questions. So if any of you has a question, you could just raise your hand and you get the microphone. In the meantime, I have a couple of questions for Janet. One is whether, in your view, supply-induced demand could explain this event. The rise of, let's say, mental health cases. So basically, the idea is that the concentration of therapists in an area could raise the number of children treated. And that might not necessarily correlate with suicides. That's one. And then another one, whether you would agree that perhaps what's going on here is to do with social determinants of health, so perhaps deprivation, alcoholism among men, or amongst children that presumably are unable to have access to alcohol, could be explaining these trends.
Yeah, that's a great point. I actually have some data for the US showing how if you hold the number of psychiatrists constant and increase the number of therapists, you get more kids who are being treated with therapy. And if you do the opposite thing and hold the amount of therapists constant and add more psychiatrists, you get more kids who are treated with drugs and actually more red flag drug prescribing. There's also, I've also looked at psychiatrists versus primary care doctors, and the psychiatrists do, on the whole, do a better job prescribing mental health drugs, but there's still a lot of bad prescribing even among the psychiatrists. So it's not having more qualifications is not necessarily a guarantee that they will do better. That was also why I included in here that I thought it was a very provocative figure that there's been such an increase in the number of therapists in the NHS over a fairly short period of time. So if supply did create its own demand, or maybe there's just a lot of untapped or unmet needs there that are now being met, right? I thought it would be interesting to look at that and see how that's related to treatment of mental health among children here. On the question about alcoholism and mental health, I mean, that is one of the things that you could count as a cost, because my understanding is that there are a lot of people who are alcoholic who are kind of self-medicating and may have some underlying mental health condition, and it's certainly true there's a lot of co-occurrence of substance abuse problems and mental health problems generally.
Questions?
Thank you. Such an interesting talk. You spoke a little bit about social media and to what extent that may or may not be playing a part here. And you touched on the fact that it's quite a kind of moving target, the way apps and websites develop so quickly. So I just wondered if you had any sort of reflections or advice for people working in that area as to what kinds of studies you think are feasible around social media, and what kind of studies you'd like to see more of to shed some better light in that area.
Yeah, I think one reason why most of the convincing evidence in this sphere is basically experimental evidence is because the survey data is so poor. So the things that you can look at consistently have to do with more internet access and maybe number of hours that somebody spends on social media. But there isn't even good data. Like, suppose you want to know how much time they're spending on Facebook versus TikTok or something. You can't get that. over any period of time. So it's just very difficult to look into it very consistently.
I was really intrigued to see how neurodivergent conditions like autism are being treated under the mental ill health banner. Would there be any value in teasing them out and treating them separately, given that there is no treatment for autism? It is a condition you are born with and you live with lifelong. And it's almost as though, if you were to take it from a disability rights perspective, society should be adapting to meet the needs of those people rather than those people being inappropriately medicated, for example. So would you see that there would be a way to do that within the data, and would there be any value in doing it?
Yeah, you could actually do that, and I have done that in the sense of treating neurodevelopmental disorders as being different from mental illnesses like anxiety and depression for exactly the reason that you're stating. So something like anxiety and depression, you hope that somebody can recover from that, whereas autism spectrum disorder or ADHD, those are just conditions that you have and you learn to manage them, right? And that's it. So, I think there is a reasonable argument for making that distinction.
Thank you so much for such an insightful talk. So my question is about the recent development of AI. As a lot of people talking about now, like a major use cases for AI is to use it as a therapist. What's your take on that? Do you think that has a potential to solve some of the problems here, or is it just going to create more problems?
Well, there's a lot of lawsuits right at the moment from people whose children used AI therapists and then died by suicide. So I think there's a lot of issues with AI. Interestingly enough, it's not used for doing important financial contracts because you need to be accurate, right? So if you have millions of dollars on the line, you're not using AI to generate your contract, but we're using it for mental health. I'm not sure that makes sense given the error proneness of AI. And the other issue about a lot of social media is that it is really very much set up to reflect what you want to hear. And I think that the therapy apps are somewhat the same. So in the cases of these lawsuits, one I know some details of, the AI never suggested that the person talk to their parents or talk to an outside person, where if they had, perhaps the suicide would have been prevented. But the person said, well, I don't want to do that, so then the AI stops suggesting it. Right? Whereas a real therapist would feel some obligation, to say, well, the person should go to hospital or even to phone emergency services.
Hi, thanks very much for the presentation. I have a question about investment appraisal. So suppose the NHS is presented with all sorts of potential programs to try and enhance mental health and well-being in young children and so forth, but there's only limited funds. How might an economist go about appraising the investment potential of spending money on this program rather than that, and that kind of thing?
Yeah, that's a great question. I haven't seen anybody apply rubric like the marginal value of public funds to specific mental health problems, but I think you could, and I think this idea of having licensed clinical mental health workers in schools could be a cost-effective thing, because you don't need a psychiatrist, right? You need a licensed clinical mental health worker who could be a therapist, less expensive, and I think that has a lot of potential to improve child mental health.
Great. The lady over there.
Yeah, when I started my nurse training, which would be 40 lots of years ago, we did a psychiatric module, and at the beginning of that they said, we warn you, every illness we teach you about, you're going to recognize symptoms in yourself, and you're going to be self-diagnosing, you've got schizophrenia, bipolar, whatever. These days, children from sort of late primary school into secondary school are taught about mental health. How much are they self-diagnosing problems which aren't there, rather than genuinely being diagnosed with stuff and self-identifying?
Yeah, I think, all of these things exist on a continuum. So I wouldn't say that people are diagnosing things that aren't there. They're probably diagnosing something that is there. The question is it really causing problems in their life, right? So it's funny because we do diagnose mental health disorders completely differently than everything else, and part of the criteria, once you check all the other boxes, is it causing problems in your life, right? If it's not, then it's not actually a diagnosable mental health issue, even if you have some of the symptoms.
Thank you for your presentation. My question is are the trends for the mental health crisis playing out similarly in the global south, or are they playing out differently?
I think it's existed in the global south for a long time, and exactly the same issue as in the global north, which was it was just something that people didn't talk about, and so they didn't collect data about it on surveys, and so there was this perception for a long time that essentially poor people in poor countries had other things to worry about, and that mental health problems are kind of a rich person's disease. And then things like, the suicides among farmers in India showed that's really not true. And there's a lot of work by people like Johannes Hofshofer and Frank Schilbach looking at mental health problems in developing countries and finding they're just as prevalent, if not more prevalent than here. If you look at some populations, like in refugee camps, incredibly high rates of mental illness, which is what you'd expect when people have gone through such traumatic and terrible experiences. So.
Right, other questions? I had a question about measurement. I know that this might be a question that only an economist could come across with, but the idea is that it could well be that when measuring suicides, we are, or the police or whoever qualifies a death as a suicide, attributes as a suicide a death that is unexplained. So some death that they don't have a clear cause, they just write it down as suicide. And I wonder whether that could as well be biased in these estimates in any way. The question is how to. Being constructive, how to identify that, right? So perhaps investment in policing services, or perhaps that would be a way to go. So netting out the effect of the quality of policing services perhaps would be the way forward. I'm just entertaining ideas here.
Yeah, so those kind of things depend a lot on the rules, like who gets to certify that a death is by suicide. I believe that in the UK there is a coroner most of the time. In the US, that has been an issue in the past, because in some counties there was a coroner and in other counties there wasn't. And so you could get like the funeral director certifying whether it was a suicide or not. They don't have any particular qualifications. So I do think there probably are changes in suicide rates over time which are associated with how it is measured, and part of the increase may be that it's more accurately measured now. The other factor is just stigma, right? So if you're a doctor, well, I could really get into the weeds on this one, but if you're a doctor and the family believes that suicide is morally wrong, and or the insurance company isn't going to pay the insurance or things like that, and there's some doubt, you probably would err on the side of like not causing a lot of problems for the family, right? But those things have changed over time. Now insurance companies have to pay. People are not thinking so much that it's a sin, and so the stigma has declined, and so that might increase the reporting.
Yeah. Question here, and then Nilesh.
Just following from what you said there about the coroner's report in the UK, is there data in the UK for kind of the outcomes of these coroner's reports of like the listed or like cause of the suicide that was sort of decided in the coroner's report or a coroner's investigation?
So, yeah, I believe that the coroner has to certify that it's a suicide. I'm not sure they would always do a lot of investigation, but at least it's somebody with medical training. Whereas if, like John was saying, if it was the police, you might get somebody who has no medical training at all. And so then what are they basing it on? They're probably basing it on, was there a note or something like that?
That lady over there? Yeah. Right.
Thank you for the presentation. So I have a question, which when I saw the time train, the time series of the change of the mental health, and also the spatial difference of the mental health. So do you think it might relate to immigrations and immigrants? For example, so for some regions that might have more diverse demographic, like the populations, then there might be higher rate of the mental health problems as children from another country, they have like limited access to the, for example, the mental health counseling service or something like that. And also they might bear more with the like loneliness or like cultural barriers and so on, also language barriers. So do you think it might have the associations with the those kind of factors?
Yeah, I think there could be associations like that. I know Melton DeSalle has done some work in Denmark looking at use of mental health services by immigrants and immigrant children. And a difficulty, like in trying to interpret the differences, is that it seems like conditional on having a problem, the immigrant children are less likely to use services. That's in a context where all the services are free and basically available similarly to different people. So it's not clear that they're going to end up being measured the same way for different groups, but I do think it would be interesting to look at. In terms of looking at suicide, so one reason for going and looking at all these different measures was that I was trying to find something which might be a good proxy that did move in the same way, because it's very difficult to study suicides in that there's not very many, thankfully, right? If you have a rate like of 7 per 100,000, that's not very many. And then if you want to split it up by male, female, split it up by whether somebody's an immigrant or not, or other things, you end up with very, very tiny cell sizes. So that's why I think it might be interesting to look at something like self-harming behavior, which seems to be quite correlated. And then there's some other things I was showing you which you probably wouldn't want to look at if you're interested specifically in suicide, because they don't track.
Yeah. So in one of your slides, you showed that the suicide rates were lower for the people who were using the social media, right?
So the negative slope was saying that the people who were using less social media had higher suicide rates.
Right. Yeah. So my question is did you have any chance to look at the mental health problem or like suicides among the children with single mother or single parents versus having both the parents, and also looking at whether having additional member in the family, whether it has an impact on the mental health symptoms or the suicide rates or not?
Yeah, I actually did look at just trends in single-parent families, because that is something that people talk about. In the US, there was a rise in single-parent families up until about 1990, and then it's been completely flat. So over the sort of period of time I was telling you with that U shape, it doesn't seem to be correlated either with the initial decline or with the later increase, just because there wasn't much going on with single parenthood over that period of time.
There's a question at the back, yes.
Good evening. So earlier on, it seemed like you identified a trend of an increase in red flag prescriptions or overprescriptions. How much would you say that this could be related to a permeation of interests of pharmaceutical companies and corporations on sort of, capitalizing on these sort of prescriptions? How do the interests permeate on, for example, the public sector in England or the private sector in the US? And how could also this be prevented through policies in the future?
Yeah, so a lot of the literature on that is in the US. And so they talk about practices like physician detailing when drug company representatives come and visit doctors and take them out for lunch or something like that, or fly them to a conference. I don't know how prevalent that is here. So I couldn't really speak to whether the inappropriate prescribing is related to that. In the US, it's certainly the case. Several of the companies that make antipsychotics have had to pay penalties for misleading advertising and misleading statements to doctors about the efficacy of those drugs for different conditions. Because most of them have not been shown to have any positive effects outside of some very narrow indications. Most 3-year-olds are not psychotic, so they don't really need an antipsychotic, arguably. And then they have these severe metabolic effects, which have also been minimized. Right? So some of the increase in antipsychotic prescribing coincides with the marketing of the new so-called second-generation antipsychotics, which are supposed to have many fewer side effects. But now the research is showing they have similar side effects in terms of changing people's metabolism in a negative way and causing a lot of weight gain in the long run and so on and so forth. So it's not clear actually that they're safer than the old ones, which everybody knew were dangerous.
So we have time for one more question.
Thank you, Professor Currie. You've talked about stigma, so you've also talked about the people's recognition of the stigma on mental health, and also the stigma, decreasing of stigma, which make people be able to speak about the symptoms. I think also explains some of the trend in here. So my question is, have you seen more questions in the recent surveys that measure those stigma, and what are those questions like?
So I guess I had a couple of things on my slide where people specifically looked at stigma. In the US, they've used the General Social Survey, which asks occasionally, not every year, but occasionally some questions about mental health stigma and the type of things they ask about, or whether people believe there's any biological basis for mental health problems, whether they would want to be friends with somebody who had a mental health problem, whether they believe that people with mental health problems should just try and get over it, things like that. And there has been improvement on those measures in the General Social Survey. There's another paper that I didn't cite here by Angermeyer et al., which is more of a cross-country survey, also arguing that there has been a decline in stigma. And I think his measure was something like, would you go for help with a mental health problem? And many more people say that they would go for help.
Well, I'm afraid it's time to draw the event to a close, but not without thanking again the presenter for such a brilliant presentation.